We might start if that's okay. Welcome to the Major Papers Review for the last 2 years. We've got 3 excellent speakers today. We'll try to make this session a little bit interactive in terms of we can take questions at the end of every speaker and you can submit questions through the discussion part of the app and we'll collect them up if you want to do that. And there'll be some live polling as well throughout the talks, and you can submit your votes or your answers using the app as well. Okay? So our first speaker is Dr. Matthew Anstey, who's a specialist emergency and intensive care physician at Sir Charles Gardner Hospital in Perth, and he's the co-director of research there. He's got a Masters of Public Health from the Harvard School of Public Health, and he was the 2012 Australian Harkness Fellow. So, welcome, Matt.
Thanks, everyone. So, for those of you who've downloaded the app, please pull it out because I'm hopefully going to get you to vote on whether the major research papers should be chucked in the bin or whether you think you're going to take them home and use them in your own unit. So let's see whether I can get this to work. Okay. So with my colleagues, we sort of came up with an arbitrary sort of way of thinking about this, which was papers that we thought were interesting to ourselves. We didn't do any sort of citation or metrics to say that these were the biggest papers. And so we've taken a slightly different slant depending on our interests. We took papers from 2015, 2016, and we may have missed out a few that you think are big picture papers, but we picked what we thought would be interesting to ourselves and hopefully to you in the audience. So I'm going to start with one from Critical Care this year, which I will profess my background and interest is in outcomes and end-of-life sort of things. So I really like this paper from Critical Care this year, which essentially took 2 international trials. So it took prowess shock and erituran, which was a toll-like receptor tried to block lipopolysaccharide. So 2 big septic shock trials. Patients from pretty much everywhere across the world. And then they took the subset of patients who were functional at admission to hospital. So they were living at home and they were doing fine before they came hospitalised with sepsis. They didn't do any intervention, they just looked at what happened to these people. So in the 2 cohorts, average age of patients was around early 60s. And so this is what's really interesting. So septic shock in these 2 trials, so in the prowess shock trial that was defined as you were requiring vasopressors for your septic shock and similar in the other cohort. And at 6 months, 35% of those people had died. And so these were functional people who turned up to hospital and at 6 months were dead. Of the survivors, so this is the other 65%, only 58% of those were at home and fully functional. So that meant that about 40% of them were either still in hospital, in a nursing home, or were requiring assistance at home. The prowess cohort looked almost exactly the same. So 30% of those had died at 6 months. Of the survivors, only 60% were fully functional. And then again, a lot of them needed help, were in nursing home, or were still in hospital. So this is sort of the flow chart that they had, pretty big numbers for these 2 cohorts, so over 1,000 and almost 1,000 in the other one. And this was pretty nice because they had quality of life recordings for these patients. 1/3 of the survivors, we'll go into in a second, pretty much reported problems with mobility, self-care, or doing their usual activities at home. So this chart shows the proportion of patients with some problem at 6 months and a year. So mobility, self-care, it says usual care, but that's actually doing your usual activities, and then some sort of anxiety, depression, or pain and discomfort. If you take patients less than 45 years of age, so hopefully our younger cohort, less problems with the mobility and self-care, but quite a lot of problems doing their usual activities or with ongoing pain, discomfort, or anxiety or depression. And then if you take patients without chronic disease, so we often think about patients who have chronic diseases may be sort of predisposed one way or another. So if you take the patients who are otherwise healthy and functional but with no chronic diseases, you still see almost a third of them having dysfunction across all those domains. They did a logistic regression analysis and they looked at the predictors of problems with mobility, self-care at 6 months. And essentially, age was one predictor. If you were mechanically ventilated or you were dialyzed for more than 14 days, which is pretty long duration. Duration of vasopressors or chronic disease status before sepsis did not impact on that logistic regression model. So the implications of this study, for me, are pretty profound. Like, you often think if you are functional when you come into hospital, you're probably going to do okay if you survive your illness. Is that we are creating a, not quite a zombie race, but we're creating a race of people who have significant morbidity and need some sort of ongoing help. I think we're still a long way away from understanding whether that is, whether early rehab will work in these people, whether follow-up clinics have a role. We'll talk about some of those trials later. I think the other thing to say is that all our trials are currently reported as 28-day mortality. I think that is not a good binary outcome, and that we should be using more functional outcomes in our trials. Interestingly, quality of life at 6 months and a year didn't change a lot. So we could use a 6-month follow-up for most of these trials if you take these two cohorts. And then finally, this has huge societal implications. Someone is caring for these people when they're at home, and we know that actually the burden of distress on carers is enormous for people like this. And so this has other societal implications. So hopefully the voting app works. Yasmin, are you running it?
I think it's being run from the back.
Okay, thank you. So this question. So next time you talk to a family member about the person with septic shock in your unit, you will talk about the potential functional outcomes for that person if they survive, or you'll just talk about the likelihood of death. So I think most of you agree that functional outcomes have a really big place in your discussion, a little bit more nuanced. Some of you think that death is still probably the most important discussion. I suppose live or die, people will often accept some degree of disability if they live, so that it might be also a fair discussion. Okay, paper number 2. So where we work at Charlie's, we do a lot of neuro. And so I was very interested in this study that came out this year from The Lancet, which is the PATCH trial. Nice acronym, which is platelet transfusion versus standard care for people who have a spontaneous bleed and they're on an antiplatelet agent. So this study was done across 60 hospitals in the Netherlands, UK and France. The inclusion criteria were people within 6 hours of having an intracerebral bleed, and they'd been on an antiplatelet agent. So that was something like clopidogrel, aspirin, for at least 7 days beforehand, and their GCS was somewhere between 8 and 15. The intervention was standard care versus standard care and a platelet transfusion within 90 minutes of seeing that they'd had a bleed. The outcome that they looked at was death, or the modified Rankin scale at 3 months. So, for those of you who may or may not have read this paper, what do you think? Patients will do better with platelet transfusions, there'll be no change, or they'll do worse? So the Australian audience is obviously very sceptical about big trials and always says they make no difference. And so that's what we've gone for. Okay, we'll see. 190 participants across 41 sites. So your chance of dying or being dependent in the platelet transfusion group was 2 times as high as standard care. The people who got platelet transfusions had a third higher chance of having a serious adverse event during their hospital stay, and a higher proportion of people died who got platelet transfusions. So I'll let that sink in for a moment. The question you should be asking is, that makes no sense to me. Do we agree with this study? So prior observational analysis has suggested that people with reduced platelet activity, the growth of the intracerebral hematoma will be linked to that. And so this study was done to try and test that hypothesis. The question that that the authors said is, we actually don't know why we got this result. Could it be that some patients actually had an ischemic stroke, so therefore dependent on collateral flow, but what we actually saw was hemorrhagic transformation, and so we're causing worsening of the ischemia? Could platelets be pro-inflammatory? I think the answer to that is likely yes. Everything we give someone that's not from themselves is often pro-inflammatory. And the thing that I actually thought probably has more significance is if you turn on the tap as fast as you want and you try and put super glue on the end, it's not really going to work. So if you've got someone with a decent blood pressure and that is what's causing the growth of the hematoma, that probably overrides any platelet forces that are there. The generalizability of this, most of the patients were on aspirin, so there was only a small number who were on clopidogrel. We were unsure of their adherence, so they hadn't done platelet function testing on these patients to see whether their platelets were, having done a rotum or something like that to see if their platelet function. And they have no understanding of why there was this high incidence or what was the mechanism of the SAEs. It was just higher across the board, so higher sorts of prothrombotic states, even infections. So understanding why those two groups is there is not really certain. But I want to see whether you guys agree with the author's suggestions. So the next time you have a patient with a spontaneous intracranial bleed who's been on aspirin, you will give platelets because that's what we always do, or I've read this trial and I'm not going to give platelets. Ian's not sure. So 70% of people won't give platelets on the basis of that result, and that's what the authors suggest. This is the best evidence that we have. It may raise a lot of questions, but in the face of the best evidence that we have, we shouldn't do something to that contrary. So I actually think this paper sort of changes my practice, which is unusual for a lot of the papers that we'll present, I think. Does anyone have any questions on that one before I move ahead? I'm happy to people to interact in this session. Please.
Is that surgical? Because some of these...
So this is spontaneous.
Yeah, even if there are spontaneous bleeds, sometimes in our institution, we had surgical interventions done.
Yep.
Though there is very little evidence for it. And that's when the issue becomes more relevant because they would ask for platelets.
So this was not with the surgery. Okay. Please.
Just in terms of potential mechanism.
Yeah.
The one potential mechanism within the list in your list was that maybe they were on aspirin for good reasons, and by reversing that you actually
Did them harm. I think that's another great suggestion. Yeah.
The other question is, in the other cases where we give platelets based on expert opinion, then there is no evidence perhaps we're doing harm also there.
I think that's a great point, and I don't know. I think there's room for maybe doing platelet function testing on these people when they come in and making a decision based on that. That to me seems more sensible than what we currently do, which is platelets might not work, just give them.
And you get the results back the next day, right?
No, you can do a rotum. You can get a sense of platelet function. Anyway, for discussion to think about. So I put this paper up here. I didn't want to put this paper up here. This paper, living in Perth, when you usually go to a conference, you can do the talk on the plane while you're going there. Living in Perth, I actually had time to think about this. And I said, do I want to put this paper up? This causes me too many problems to think about, but it is a major paper from the last 2 years, so we sort of need to discuss it. So I picked just the septic shock part, and I wanted to talk about it not necessarily from the results, but I'll get you to vote on that, but from the methodology. Because, I don't know, I actually think that these people involved had good intentions and went about this way in a very sensible way, whether you agree with what they came up with or not. So I'm going to just try and highlight what they did. So I'm just going to tell you what the other papers, if you haven't read Sepsis 3.0 and all the opinion papers that have come out, this is just a quick synopsis. So the new sepsis definition is basically your immune system doesn't work quite right in the setting of an infection. Label sepsis is not an illness so much, it's a subset risk group of patients with an infection. So if you're a GP, you see lots of people with infections, they go home on oral antibiotics and they're fine. We see the people who have some sort of organ dysfunction as a result of that. And so you may have seen this algorithm for sepsis. So you have to try and decide, does this patient have a suspected infection? If so, you do a Q-SOFA, which is the respiratory rate, mental state, and the blood pressure. If that is greater than 2, you look for organ dysfunction, and if it's greater than 2, then you call that sepsis, and then we go on to the septic shock definition. So that's the Q-SOFA, and essentially it screens for patients based on their outcome. It doesn't tell you whether they have infection or not. You've already decided that in the first step. That's your assumption moving into this algorithm. If you could apply these to other groups of patients, but that's not what this was used for. Okay? And then based on your Q-SOFA, that gives the mortality risk for those patients. Why is that important? Well, we risk stratify patients all the time. We see someone who comes into the emergency department with a chest pain, we re-stratify them based on their risk. This is a re-stratification tool for resource use in the hospital. So septic shock, we used to say that septic shock was sepsis and a blood pressure lower than 90. Maybe it's actually just someone who's got an infection that we want to admit to our ICU. That's probably what we say on ward rounds. This patient's got septic shock. We never go through and tick all our little definitions. They're just there and on presses. So Society of Critical Care and ESICM put together a task force to revise the definitions. They undertook a systematic review of all the papers out there and did a meta-analysis, and then they did a Delphi study, which is essentially ask everybody what they thought and then prioritise what they thought were the most important variables to come up with an end list. And then they tested those variables from 3 large cohorts. So the Kaiser Northern California cohort, which is over 1.8 million patient encounters. Pitt, which is 1.3 million in the surviving sepsis campaign data sets. And the date range from them were about 2008 to 2012 or 13. So relatively recent cohorts. And as you can see, that's pretty good, large, robust data sets. The systematic review said, well, everybody seems to be defining things differently, which is problematic. But from those problematic definitions, the things that we think are most important are hypotension, lactate, and receiving vasopressors. And we will test these in our different cohorts. They created 6 patient groups. So either you were hypertensive after fluids or you weren't hypertensive after fluids. You had a lactate greater than 2 or a lactate less than 2 on vasopressors, not on vasopressors. And they went through and tested those variables in those different groups to look at the outcomes from those patients. So the results. The patient group, I should have put this as a poll question. You would have said the patient who needs vasopressors and has the highest lactate has the highest mortality. That's not surprising. But that's what the new definition is. So that's the patient group who's highest risk of dying. So that's the patient with septic shock. And then they added a definition to that, which is, subset of sepsis in which the metabolic, circulatory, cellular abnormalities are associated with higher risk of mortality. So that's the new definition of septic shock, and so now people are trying to adapt that to new papers and new protocols moving forward. So I just like a feeling from the room. Sepsis 3.0, way to go, we love it. This is no better than SIRS, this is sepsis 0.3, and I still don't understand what people are talking about. So if you can vote on one of those three, that would be great. So the room supports sort of the online comments that you've probably seen, that most people don't think this is any better or moving us forward in any way. Hopefully I've convinced you somewhat that they had good intentions. They went about it with a very useful methodology. I think the methodology was probably as good as it could have been. You always have to question the assumptions that they have in their Delphi process moving forward. Okay, please.
Remembering how SIRS came about,
Yeah.
allegedly it was on the back of a beer coaster in San Francisco, and that was the methodology for the whole sepsis, severe sepsis,
Yeah.
shock, SIRS stuff.
Yeah.
At least there's some methodology here.
Yeah, I think so. I don't know. And at least people may then be more prominent about and rigorous about the definitions we use. I know there's someone presented recently at Milan from Australia showing like SOFA versus Q-SOFA versus SIRS, and SOFA itself is the best predictor of everything. But people aren't going to do the 5 domains of SOFA on every patient. So the Q-SOFA is, a tip of the hat to the places that are developing countries that don't have all our tests as well.
So again, sort of showing my bias towards sort of advanced care planning. I really like this paper. I don't think that it is easy to understand their methodology, to be honest, but I'll walk you through their assumptions. So this paper is saying what happens if we talk to patients either before they come to ICU or when they turn up in ICU and they have some sort of life-limiting illness. Again, using a very large data set. So Premier is one of the hospital networks in the US, has over 2,000 hospitals, and they use data from 2008 to 2012. And so they looked at 2 million patients with chronic life-limiting illnesses. So again, really nice large data set. And as you can see, there's the rise of these papers where you're using data sets to try and ask and answer questions. They used a design which is a Markov simulation model, which is an economic modelling technique, and they modelled a variety of scenarios for advanced care planning. And they talked about advanced care planning when you turn up to the hospital or when you're in the ICU, and they distinguished them as ICU-based palliative care consultation, which could be done by the intensivist or the palliative care team, or in-hospital planning, so there's discussion before they turned up. And then they modelled, based on the billing data from Premier and the length of stays of these patients, what would happen if you did this as routine practice. They used the best literature that was available, which, all of these things are based on assumptions, and so the assumptions underpin this study, which is the literature best suggestion says that if you have an in-hospital advanced care planning, you reduce the likelihood of ICU admission by 37%. If you do that same conversation in ICU, then you're going to reduce the length of stay by 26%. So the assumption already is weighted towards an earlier discussion has better outcome. But that's what the literature says, and so they then modelled that. This is how they defined serious and chronic illness within the cohort. And so there's nothing that surprising there. Essentially, it is cancer, dementia, very elderly and multiple comorbidities, and then things that you'd expect someone to die from. This is how they did their modelling. You don't need to follow that, but obviously some patients are admitted straight to the ICU. They don't have the opportunity to have a pre-ICU discussion. So therefore, they modelled the chance of that happening and then the chance of the different possibilities of you having a discussion. They also modelled the possibility of you leaving the ICU, going to the ward and having a discussion and then coming back. They did a lot of modelling, and basically, I'll show you those results in a moment. So if you meet that inclusion criteria for all those different definitions, you know, cancer, dementia, all those other things, 31% of them used ICU in 1 year time period. So that's not a bad definition, I think. A third of them will use it. I think that's reasonable. The results, I think, are underpinned by their assumptions in the base model, but essentially preventing an ICU admission is much more effective in saving costs than reducing length of stay. And therefore, early advanced care planning and hospitalisation has the most potential for cost savings. This was a cost savings paper. I know we talk about quality for patients. This was only looking at cost and length of stay. I think this has enormous implications for patient quality of care as well, but that was not discussed. And so from their current literature, they estimate this would save 10% of all ICU costs in the US. And I think from memory, and Michele, you might correct me, that US critical care is 2% of their GDP. Yeah, so that's a lot of money. This is how the modelling works. Basically, along the bottom, you see you see various effectivenesses of the consultation and how much that would affect the costs. So more effective, less effective, you have different sort of ranges of effectiveness. So this vote is now a little bit more philosophical, or based on that paper at least. So it appears that it's more efficient to have goals of care discussions before you get to ICU. So is it our role to take over the rest of the hospital and have these discussions because other teams are not doing it well? Or should we make other teams get better at it? So this is like a big question for us as a specialty going forward. I don't think I can get anyone to vote on how we make our other teams do better at that, but I think that's probably, you know, the sense in the room. Okay. Please.
Now, maybe there's someone from the Austin who might be able to help me, but I recall just reading a recent paper, thought from the Austin, where they looked at all medical emergency team admissions to ICU, and they were focused specifically on patients with life-limiting diseases, very similar to that list. And they found that 25% at least of those patients who were expected to die, no one had ever had a conversation with them pre-ICU about what their wishes would be and limitations in therapy and all of that. And so that's an Australian study, and I think it fits quite nicely with this one. Even if you don't mention costs, there's a big cohort out there that are knocking on our doors where we're not being proactive in checking out what their wishes, etc.
So for our own hospital, we've done a similar thing. It's 30% of our patients having a med call have some life-limiting illness that hasn't been picked up. Ian and I have a paper under review that essentially shows some ICU advanced directives. And essentially, we're not seeing anyone with advanced care planning turning up to our ICU. And that's across the country.
In Alice Springs, we had a look at our frequent attendance into the hospital, and we found that if you attended into the hospital 5 or more times in the previous year, you were 25. That represented 25% of our admissions into ICU or HDU the next year. So we actually got an national RC grant and are looking at whether case management of those patients, those high-risk patients,
expose yourself to the obvious criticism that, sure, letting people die is always going to be the cheapest option. You know, that's self-evident. So I think you have to be very careful when you do this kind of study that it shouldn't actually be about cost. It should be about doing what's right.
I think that's fair. Yeah, please.
I respectfully disagree. In that, as long as whatever your intervention is,
Disrespectful of this.
in whatever you do, as long as you indicate that the primary intention is to improve quality of care, when you're going to the funders, you've got to demonstrate a saving of money, because otherwise there's no way they're going to get behind the lead time and the cost of the intervention to actually.
I think the other thing to say is that from that inclusion criteria, the list, no one would be surprised if those people drop dead in the community. So, you know, they turn up to hospital and we feel like it's our duty to save them, or they're going to die anyway. So, Mark.
I think the first step towards solving the problem is owning it, and I think ICU should own this space. It's part of really our work that we do is we have a limited resource that is ICU, and part of our actually day-to-day management is managing that resource effectively. And what I say in my hospital is I don't want anybody to advocate for dialysis, ECMO, whatever, if they cannot implement it themselves. So I don't want a junior ED registrar saying we're going to give granny ECMO, dialysis, etc. That should really be, I think the intensivists should own that space. I'm obviously agreeing with that.
Cool. Yasmin, how am I doing for time?
I think we're about at time.
Okay, I'll do my last paper. So, you know, when you get asked to talk, you can talk about whatever you like. So I thought I'd talk about one of my own papers. I'm not going to talk so much about this in terms of its results, but because of the way that we did this. So I was involved in this when I was in the States, and it's only just been published. But it was a very interesting study. So you've probably all read the literature on medical ICUs and early mobilisation. So Schweikart's stuff, Morris's stuff, and then there was a paper, I think, by Moss this year on early mobilisation in stroke patients that seemed to show that they had a worse outcome. So surgical ICU patients had never been looked at before, and that was because I think, you know, people have wounds, you think, oh, we don't want to move them, they've got epidurals, all those sorts of things. So we decided to challenge that hypothesis. It started out as just 2 ICUs, so it was Beth Israel where I was and Mass General, and then because of the PI, who's originally from Germany, spread out to Germany and Austria. Inclusion criteria were people who in the surgical ICU who were mechanically ventilated for less than 48 hours, but you expected them to stay ventilated for another 24 hours. So it wasn't just a quick in and out, you did expect them to be ventilated for a period of time. And they were randomly assigned to standard care. So standard care is, you know, usual care with all the daily wakening trials, goal-directed sedation, spontaneous breathing trials, weaning protocols, all that sort of stuff, the sort of protocolized sort of American style of care, or standard care plus early goal-directed mobilisation. So I'm going to talk a little bit, hopefully here, about what early goal-directed mobilisation meant. So this had to be a cost-neutral intervention. So we didn't have any more physiotherapy staff. Physiotherapy staff were there, like in our own units, to do whatever they were consulted to do. What this did was it assigned usually one of the clinical nurse leads on the ward to be the facilitator in conjunction with the attending or the consultant who was doing the round to decide the daily mobility goal. So at the beginning of the day, they went, you know, this patient meets the inclusion criteria, we randomise them, and they end up, and we assign a goal. And now I'll show you the optimal mobilisation score, which goes from no mobilisation to 4, which is ambulation. You set your goal, you try and work with your bedside team to achieve that goal in the day, and then at the end of the day, you circle back and you say, was that achieved? And they say no. You say, how can we make this happen tomorrow? Okay, so it really is a sort of a closed loop of communication that really requires teamwork from people who are the orderlies moving the patient all the way through. MSOM's protocol essentially goes across 4 phases. from no activity, which is, I suppose, no, and to in bed, sitting, standing, and ambulation. There are criteria that, safety criteria, like all the other trials, they're no different. The first 2 phases, at least in our institution, were done by the bedside nurse. The last 2 phases were done by, in conjunction with the PT or the physiotherapist. So the outcomes that we looked at was the mean SOMS level. So, did you get 1 to 4, 0 to 4? Your length of stay, and then this functional independence measure score. And there's 2 domains in that. One is locomotion, so whether you can walk, and then how will you transfer. So this led to shorter length of stay, unchanged length of stay, longer length of stay. I think that's nice. I probably wouldn't have put up a negative study that was my own. So, so mobilisation level 1.5 versus 2. What does that mean? That's about a 1 scale difference. It's difference between being in bed to sitting on the edge of the bed. That might be something. Length of stay reduced by 3 days. There were more adverse events in the intervention group, but none of them were all that important. It was like people bruising their knees or something like that. Nothing serious, no tubes or anything like that. And the MFIM, so the people who were more independent at discharge improved in that group as well. So the clinical implications of this, one is that it was the first SICU mobilisation trial. It had a teamwork basis, the facilitator to work on this. There were no changes to ventilator-free days, sedation-free days. Our conclusion to that was that meant that we were doing all that standard care stuff the same in both groups. Earlier trials may have been, people said that maybe all of this sort of intervention was a bundle that improved sedation, improved everything else, and maybe it's just the sedation changes that lead to improvements in outcomes. We saw improvements in outcomes without changes in sedation. The other thing is we started early. So it's not waiting till the patient's been in bed for 7 days and you go, oh, they're not getting out of here. We decided, looks like you're going to be ventilated for more than 24 hours, let's go. Generalisability, there were no new staff, so it should be a cost-neutral thing. It requires a huge culture effort to actually undertake this, though. And for those of you who've done this in your own unit, it's not easy. Multiple sites, so that is also interesting. And so this is my last question, and then I'll hand over to my colleagues. Do people have an earlier mobilisation team or program in their own unit at the moment? Yeah.
I recently had bacteremia, and in the morning I get up and feel like when the fever came back and wanted to get back into bed. My body was telling me that for years. When people feel well, they get into bed. Now, do you think there's any merit in looking at those patients who still have got an acute phase response and be more gentle with them? Because quite clearly, if they're recovering from the illness and the infection's gone, this is a good thing. But what about those patients who've still got an ongoing SIRS response? Do you think we should look at these patients differently?
I think it's a good concept, because if you think about feeding, we think that maybe undernutrition is better in the acute phase rather than full feeding or super maximal feeding. The counteract to that is that you lose 1% of lean muscle mass per day that you're immobile in bed. And if you're 70 and you're already frail, that might, 3 days may be the difference between getting home and going to the nursing home. But I think as a pathophysiological question, I think it makes sense. It hasn't really been looked at to my knowledge.
Thank you, Matt. That was great.
What was the answer to that?
So our next speaker is Associate Professor Michele Balas, and we were very lucky to hear from her in the plenary session. She's from the Ohio State University College of Nursing, and she's a world leader in interprofessional research improving outcomes in older critically ill patients. Welcome, Michele.
Thank you. Thank you. So I'll catch us up here. So you have the great privilege of hearing from our final speaker. Again, thank you for the opportunity to present with us. I do have to admit we did have an interesting way of choosing our papers. One of the things that we wanted to do was to find one that was more controversial to make some liveliness in the room. Hopefully we do that. I have to admit I kind of picked mine out of the blue. And the first one that I'm going to share with you is something that I would never normally pick. But I was so fascinated with the topic and what the device actually looked like that I couldn't resist. Plus, John Devlin, who's this great pharmacist from the US, thought it was one of the more important studies that came out this year. So the first thing that I'd like to present today was an article that was presented by Patel and colleagues from the University of Chicago that looked at the effect of non-invasive ventilation delivered by a helmet versus a face mask. Has anybody looked at this article yet? Yeah? So it was a randomized controlled trial. We know the reasons for looking into this intervention, there's a number of important ones. We know all of the dangers associated with endotracheal intubation. We obviously want to keep our patients off the ventilators as long as possible so we could do the really important stuff like delirium screenings and early mobilization, in addition to their, protecting their airway. But there's no problems with invasive ventilation. If we could have a therapy that works and prevents our patients from being intubated, that would be a great thing. So what they wanted to do was to determine whether this non-invasive ventilation delivered by the helmet improves intubation rates. That was their primary outcome among patients with ARDS. It was a single-center randomized controlled trial conducted from 2012 to 2015. To be enrolled in the study, you had to be over 18 and require non-invasive ventilation for at least 8 hours for the management of ARDS, which they used the Berlin criteria for. In terms of exclusion, people undergoing a cardiopulmonary arrest with a low Glasgow coma scale, if they didn't have their cough or gag reflex, elevated ICP, tracheostomy, pregnant, or refused endotracheal intubation were excluded. So what they did is, after 8 hours of being on non-invasive ventilation, they were randomized in a one-to-one manner to either a face mask or this helmet. They actually planned to enroll, their target enrollment was 206 patients, but interestingly, I'll tell you how that changed in a little bit. The control group was non-invasive ventilation like you're probably used to in Australian ICUs, unless you're really far advanced and are using this technology already, the single limb kind that's hooked up. And the intervention was this helmet. Well, originally when I thought, well, what does this helmet look like? The first thing that came to me was our friend up here, Dorth, who we know and love very well. But I couldn't imagine what this, could it be something that different than what we're using in everyday clinical practice? And in fact, I was wrong. It actually looks a little bit worse to me, being the nurse that's going to have to care for this patient. It looks like more of we went to the video game museum that you have here. My husband has a new high score from Atari in the 1990s, if you ever take a walk up here. But this reminds me of one of the ghosts from Pac-Man, from the old Pac-Man. So I'm not really quite sure which one was worse. So in terms of what they did, both groups had very similar titration of non-invasive ventilation, and it was protocolized. They increased their PEEP and inspiratory pressures per the set protocol. They too got the daily interruption of sedation, awakening and breathing trials, and early mobilization performed per standard of care each group, and all decisions were made by the patient's, obviously, primary care team. They define pre-specified adverse events. We know that in terms of the regular non-invasive ventilation, we worry a lot about skin breakdown. Well, with that helmet device, I guess the skin breakdown would obviously, it's kind of stuck on your head, so it would be more around the clavicles and in that area. So what they found? Well, importantly, they had planned enrollments, and in the first DSM interim analysis, the study was actually called for efficacy. They met efficacy endpoints way before they were supposed to in the study. But the DSM said they should go on with the study since the technology wasn't available to other people, so let's get more people enrolled so if we can really determine if this efficacy is sustained with more enrollment. However, then this study came out that looked at and showed increased mortality in patients receiving non-invasive ventilation compared to high-flow O2. So then they cut the study after that because then they thought maybe it's a problem. So in the end, 39 were enrolled in one arm, 44 in the other. The patient characteristics, if I just get back, they're all the same. There is no statistically significant differences between groups. middle-aged to a little bit older, of course, mainly male, and, well, surprisingly, mostly non-white, which we never really see in ICU studies that are published. So that is a little bit different. Patients' respiratory failure was covered several different aspects. Pneumonia in the patients with the helmet group, there was a little bit more pneumonia compared to the face mask group, but all of their other SpO2, FiO2 things stayed the same. What did they found? Well, one of the things, and we'll talk about the big major findings, but a lot of this has come up in recent editorials that have come out about how this therapy might possibly work. But both groups had they were similarly on the non-invasive ventilation for similar periods of time, and they both had about the same O2 sats. There were, however, differences in sustained levels of PEEP and FiO2. Okay, so this is a possible explanation of why this therapy may possibly help. So, for example, they were able to sustain that PEEP levels much higher in the helmet group as opposed to the traditional non-invasive group. They were actually able to titrate that PEEP as well, a little bit better with the helmet compared to the traditional group. So in the end, they did find efficacy with their primary outcome endotracheal intubation rates, as you can see in the helmet group, was about 18% compared to your traditional face mask non-invasive ventilation, 62%. Reason for intubation, interestingly, did differ between the groups quite a bit. Patients in the traditional face mask group were intubated more for primarily respiratory reasons, as opposed to the helmet group was intubated more for neurologic injuries, neurologic failure. Great secondary outcomes also achieved with the helmet in terms of ventilator-free days. ICU length of stay were both statistically significant, and also hospital and 90-day mortality was seen to have some benefit with the helmet group. And here's their beautiful representation of that. So, importantly, there was very few adverse events. There's the deflation of the helmet that I pictured in my head again when I'm thinking about this therapy. But deflations in the helmet group were very low. There was very little ulcerations in skin in terms of the pragmatics of caring for these patients on a daily basis. Very little adverse events. So in terms of limitations and conclusions, the study seems to support the benefit of this relatively new type of therapy that may be coming to Australia anytime soon. Most of the improvements seem to be related to the fact that you can keep PEEP levels higher in this helmet versus the non-invasive group. That seems to be the biologic plausibility behind it. Limitations are obvious: single-center randomized control trial, new technology not tested in a lot of different settings. So that was my, that's a kind of weird study, but thought maybe it'd be used too. Have you guys seen such a technology yet? Is this something that you're using on a regular basis? No.
Used to use it in the UK.
So everything old is new again? Everything old, new again? Okay, so this other one, I think you'll see the reason I chose this one. This is a little bit of an older study. This was from 2015. The impact of hospital and ICU organizational factors on outcome of critically ill patients. So it's results from the EPIC study. You guys heard of the EPIC study? So we know that outcomes of critical illness vary, right? We've had some great presentations during this conference that show things like age, severity of illness. Intuitively, the sicker you are, the older you are, the more likely you die. There's also evidence, and it's rather controversial evidence, but it's beginning to develop that organizational factors, either at the unit level or at the hospital or even higher level in terms of systemic reimbursement, also might have something to do about whether or not our patients survive a critical illness. In terms of the nursing literature, outside the ICU studies and in the U.S., there's been several studies that have been conducted by Dr. Linda Aiken, who've shown that staffing patterns also play an important role. And in terms of our intensivist friends, I don't know if you guys get caught, you guys seem pretty chill and probably don't take sides either way, but the idea of open and closed units, you open or you closed here?
No one's chilled about that.
So everything's closed, so they're, okay, fine. So then it's not pretty controversial here. So the purpose of this study was really actually to look at what are some of the organizational factors that we believe might have some kind of impact on our patients' recovery or survival after an intensive care unit admission. It was a secondary analysis of the EPIC study, which was an international multi-center observational study. Over 1,200 ICUs from 75 countries, so really nice international representation. And it included all patients over age 18 who were enrolled in a participating ICU in the 24-hour period where they were recording all of their outcomes of interest. They collected SAPS-2 and SOFA in terms of severity of illness, and also the demographic, physiologic, bacteriological, because that was part of the original study, outcomes from chart reviews. And they followed several different organizational factors. The first thing they looked at was type of hospital, whether it was university-affiliated or non-university affiliated hospital. We're doing the same thing in our SCCM initiative, where we purposely enrolled academic and non-academic big community centers, or community centers, knowing that in the U.S., that's primarily where care is delivered in the intensive care units in the community setting. They looked at things like the bed capacity, how big they were, in terms of bed, what kind of services these hospitals offered, whether it was an open or closed unit, the number of admissions per year, whether or not they had subspecialties. I just learned now that you don't let surgeons become intensivists in Australia. And whether they had that 24-hour, right, I was kind of born and raised with surgical intensivists, so that was surprising to me. The number of ICU beds and nurse-patient ratio, and they also looked at the nurse-patient ratio both on day shift and night shift. And again, this is where the U.S. and Australia differ quite a bit. So in terms of the cohort of people, again, mid-60s, mainly male, moderate severity of illness, nicely separated between medical, surgical, and mixed units represented in this study. And nice mix of where they were admitted from, whether it be the emergency department or medical surgical floors, patients with a variety of comorbid conditions. Half the patients were mechanically ventilated during the day that they collected data, and 9% were receiving the renal replacement. ICU mortality, 18%, seems pretty congruent with what I'm hearing at this conference where you guys are falling, and hospital mortality rate around 24%. ICU length of stay rather long, 9 days, and hospital length of stay 20. So I don't expect you to read all of the individual comparisons up here. What I did was color-coded them based on the type of the world. And Oceana, do you guys really go by this? No? I was surprised by that. But what I did was the comparison group was North America. And anything that was statistically different from that first red column showed up. So, for example, in North America seems to have a significantly higher amount of university or academic medical centers as compared to Asia or our friends in Western Europe. Same with non-university hospitals. Microbiology is expected pretty high in most of the countries throughout, much lower in Eastern Europe, and again, similar with East. So nothing too surprising there. What is interesting is the use of intermediate care units. So do you guys have the intermediate step-down units here? ICU step-down medical surgical floors. They do seem to vary quite a bit by the region of the world that you're coming from, with quite variability there. Closed ICU, again, obviously the general trend throughout the world with significant differences. You guys are actually the highest amount of closed ICUs. And the number of staffed ICU beds. So when we look at, and this is pretty interesting too, the number of in-house intensivists. Pretty consistent across the world. Volume of ICU admissions differ just a little bit. So in terms of nurse staffing ratios, you can see there is quite a bit of variability in nurse staffing ratios throughout the world. A lot of this could come down to what nurses do and what they're responsible for at the bedside. So, for example, you guys obviously don't have respiratory therapists for your mechanical ventilation management, and you're responsible for that. But you have one of the lower nurse patient ratios throughout the world, both on day and night shift. And what they found was a lot of the variables that people expected to protect patient or confer some mortality protection risk, those variables that we thought might help, none of them really held up. So there was no difference between university or non-university, whether or not they had the microbiology or ED or anything on this chart, whether even they had the intermediate care beds or in-house intensivists. Sorry, close. But not quite statistically significant in terms of the multivariable modeling. The things interesting, there was only 2 things that seemed from this study to confer protection against mortality, and that was whether or not you were admitted to a medical intensive care unit. Don't find that too surprising. But this was one of the first studies that actually suggests that there is quite a benefit in terms of having lower nurse-patient ratios. This is something near and dear to me. Again, I think we can all probably agree that having more nursing presence at the bedside would be beneficial to our patients. It's one of those stupid research studies that no federal funding agency is ever going to do, because if it's proven positive and it shows that, yeah, it does matter that you have somebody more at your bedside caring for you, then hospitals are going to have to pay for that and nobody's going to want to do it. But that's why I think this, one of the reasons this study is so important is because it does begin to give us evidence, stronger evidence than we've had before in intensive care units for the benefits of lowering those ratios and having more nurses at the bedside to care for the patients. So in the end, the only 2, after adjusting for the region of the world you're in, your SOFA, age, sex, and comorbidities, the only 2 things that really mattered in terms of mortality rates was whether or not you're admitted to the MICU and what your nurse staffing ratio looks like. How are we at time? Any questions? Great. I'm going to turn it over to you so you have some time left and try to catch us up a little bit. You sure? You sure? Okay. Okay. So this study I chose because I know there was some interest in looking at the longer-term outcomes of patients that were admitted to the intensive care unit. This study was just published not too long ago, a couple months ago, from our friends up in mainly Canada. It was published in the New England Journal of Medicine. And what they did is they looked at the 1-year outcomes of caregivers of critically ill patients. Why do we care about this? Well, as has been touched before, unpaid caregivers, particularly in the United States, are the labor associated with caregiving in the United States is huge. $27 billion a year. In Canada, $642 billion of unpaid caregiving in the United States. Now, you can argue whether that's a moral responsibility or not. It is a significant amount of caregiving that's occurring that's unpaid. We know that particularly for patients that require prolonged mechanical ventilation, they frequently have needs that ongoing needs that last years after ICU discharge. And a lot of that caregiving comes down to families, in particular spouses, and in particular women are often the unpaid caregivers of these patients that survive a critical illness. And we also know from smaller studies that caregivers themselves are at risk. We all heard of PICS and PICS-F, post-intensive care syndrome family. But we know the effects of an intensive care unit stay don't only affect the patient, but their loved ones, and particularly with their health-related quality of life. A lot of challenges there with emotional distress and the burdens that they experience while having a loved one in the intensive care unit. So the purpose of this study was to actually look at this large cohort of caregivers and to identify the subgroups of caregivers with distinct health trajectories. So what do those health trajectories of the caregivers in companionship with the patient look like? And what they thought beforehand, their hypothesis was that if a patient was sicker and had disability at 7 days after ICU discharge, they'd probably have higher caregiver strain. And also if the caregiver had less support or more restrictions on their personal activities, so they're not able to go out and do those social things that they needed to do to form relationships and take care of themselves, they'd have worse outcomes. So again, it was conducted over a 7-year period as part of the Recover program in Canada. The caregivers were defined as a family member or a friend who were primarily responsible for providing the care or coordinating care after a patient was discharged from the intensive care unit. So it was pretty broadly defined. All the data were collected with the use of questionnaires. So they used questionnaires at 7 days, which was considered the baseline, 3, 6, and 12 months after the ICU stay. They measured several different outcomes. They measured depression, psychological well-being, physical and mental health, and those components were measured using the SF-36. They also, because they were interested in a variety of caregiving outcomes, used a medical outcomes study for social support, measuring whether or not these people had social support in their community, a mastery scale, looking at how confident they felt in their caregiving, whether they thought they were prepared and able to deal with all the demands of caring for a post-ICU patient, the caregiving assistance and impact scale, and personal gain scale. So in the end, they analyzed, had a pretty good retention rate in this study. So at the end of the 12 months, they had 150 completed the assessment, and in the analyzed 1-year cohort period, they included 238 patients. So 55% of those enrolled completed all 4 assessments. In terms of what the caregivers look like, they were typically what you'd expect, mainly female, low to mid 50s, caring for their spouse, and mostly married or common law. Rather educated, and over 40% had an annual income of greater than 70. So they weren't particularly poor caregivers in this study, which is important, and you'll see why. They analyzed the caregivers by 2 different groups. So they looked at caregivers who had depression, but that depression decreased over time, and then they also looked at caregivers whose depressive symptoms remained high over time. So they divided them into those 2 different groups, and we're looking at different things there. And what they found, some interesting characteristics between these 2 groups. First being the caregivers whose depressive symptoms remained high throughout the 12-month period, they differed significantly from those whose depression decreased over time in a number of important ways, in particular in their mental, physical, and mastery scales. And I'll tell you what that means in just about a second here. One of the things that we're always limited to in our ICU studies is that we lack comparison data, right? We don't know what these people or the caregivers look like before they've come to the intensive care unit. But what this study does show us is that depression in these caregivers is high. Starting out and then decreasing over time, but still well above what you would consider country or area controlled levels of depression. Similarly, psychiatric and mental health improved. Oh, why do my slides look so terrible? They look so pretty on the other things. Both mental and physical health improved over time, but we're substantially different from normal caregiver peers. Normal caregiver or age and sex match controls. And this just shows the trajectory over the time. So in the end, what they found was caregivers, so those people that are caring for our ICU patients, who had more depressive symptoms, less psychological well-being, and worse mental health. What did those people look like? Well, they were, interestingly, younger in age than the others. It had a greater effect on patient care and other activities. They had less social support, less mastery, so sense of control over what's going on with their life, and less personal growth. And interestingly, in terms of physical health, that's where the monetary components are. People that who have a lower income the caregivers seem to do much worse at that 1-year outcome if they had lower money. So in the end, we know what the study showed us is that our concern over depressive symptoms among caregivers in particular should be high. It's much higher than age and gender-matched peers, that it is a problem in our caregivers, that there's certain things that might want us to trigger us to look closer into developing interventions for these patients, in particular teaching and the education that's needed to care for the complex patients that they have, and looking into extended outpatient services not only for the patients, but maybe some beneficial psychiatric input for their caregivers. Thanks.
We'll move on to our last speaker before lunch, Associate Professor Ian Seppelt from Nepean Hospital in Sydney, where he's a senior intensivist. He's also affiliated with the University of Sydney and the George Institute, and is a part owner of a very nice vineyard near Orange in central New South Wales.
Yeah. That's the important bit. That projector's got
There's a problem with the projector.
major obstructive jaundice. It's been a bit intermittent, but we're stuck with it. So this is... very good. That's why you're the IT person and we're not. So, very good. So to finish off, we did collude a little bit to try and divide up areas of the literature, and I've got a few areas that haven't really been covered by Michele or Matt. I'm going to spend most of my time on the first two sections there. 3 and 4 relate to two small negative papers written by the same first author who just happens to have had a paper in JAMA and one in the New England Journal in the same week last year. But both relate to clinical trials group studies, and feeding we may or may not get onto. Talking about neuro stuff, there's been a couple of very interesting publications in the area of traumatic brain injury. So this is going back to the Australian and New Zealand DECRA study that many people in this room were involved with, where we had a very surprising result that decompressive craniectomy worked. It decreased ICP, there's no doubt about that whatsoever. But when we looked at outcomes, and I'm just going to draw your attention to this because this is very relevant for how we interpret rescue ICP. The conventional way of looking at the extended Glasgow outcome score is to divide it between 1 to 4, which is bad, and 5 to 8, which is good, and draw a line between severe and moderate. The point of contention is for this upper severe disability section, and whether that's an acceptable outcome or not, which will be relevant in a minute. So for DECRA, it was dichotomised that way, and what we saw, to our great disappointment, was that at every point, patients had worse functional outcomes in the decompressive craniectomy group and not the standard care group. What has just come out about 6 weeks ago was the long-awaited report led by the British group in Cambridge for rescue ICP. This is a slightly bigger study than DECRA with 408 patients. It took a bloody long time to recruit, 11 years, and that's certainly one of the issues, that this is just such a hard group of populations to do RCTs in. The primary 6-month endpoint and secondary 1-year endpoint. There were certainly some differences. To get those numbers, rescue ICP had broader inclusion criteria. DECRA was very, very tight. Diffuse traumatic brain injury, no undrained mass lesions, no post-operative mass lesions, and a sustained ICP above 20. Rescue ICP required an ICP above 25, did allow drained mass lesions provided the bone had been put back on, and gave more options to the surgeons. So DECRA was just a bifrontal decompressive craniectomy. There was the option in rescue ICP to go bifrontal or lateral, depending on the surgeon and the patient. So on the left is the DECRA operation. On the right is a large lateral procedure which was allowed as an option in rescue ICP. Big difference is that they drew the dichotomy differently, and they decided that this upper severe group was an acceptable outcome. So lower severe is someone who's totally dependent, better than vegetative, but totally dependent. Upper severe means that these people can do some things for themselves, but it's still a pretty disabled population. So looking at all the individual groups here, and these couple of graphs show the worst outcome on the left, black is dead, which is appropriate, and the best outcomes on the right, which are very, very small bars. But you can see that there's no doubt that in rescue ICP, the results were more like what we would have anticipated and not quite the results that we got in DECRA, where operating on these patients saved lives. That's very, very clear, but it also increased the number of vegetative patients, that's the red ones, and the number of lower severe disability, so these are the not vegetative but totally dependent patients, which are the orange ones, so that's all bad. In terms of the good outcomes, or the really good outcomes, there's not that much difference. Though at 12 months, there were more in the second best group on the right there. But depending on where you draw the dichotomy, this is what the researchers did, and claimed quite a significant benefit, manifested mainly in this line between the lower severe and the upper severe disabilities, and called that a good outcome. If you did what most other people have done in this sort of research and draw the dichotomy there, it's a much less obvious benefit. That's important because the way this was written up and published was as a positive outcome. And in fact, I found the editorial chilling, because the way the editorialist wrote it up, it was that we now have to have another look at the role of decompressive craniectomy to benefit our patients. And the editorial was written that way. So, sticking in the TBI sphere, this is the Eurotherm 3235 study, which was published just on a year ago, which again fits into this category of large, extremely difficult and ultimately very disappointing RCTs, but which were trying to address major questions. So in terms of what do you do when you have resistant intracranial hypertension not responding to basic treatments, the options we've already had have been hypothermia, drugs, and particularly barbiturates, and decompression. So we've just talked about decompression. So this trial was looking at the role of hypothermia for intracranial hypertension. There's been at least 20 RCTs of hypothermia for TBI, which have all been problematic, usually because it's been applied too late, involved warming cold patients and chilling warm patients in at least one of the big studies in the US, and various other methodological problems. However, it's reasonably clear that if a patient with a TBI is febrile, bringing the temperature down does fix the ICP. And certainly, anecdotally, I think we've all seen that in individual patients. Question is, if you go a little bit further to mild hypothermia, this is the 32 to 35 degree range, does that actually improve functional outcomes, or just ICP, or nothing? And that's what this study was looking at. So the threshold was 20, it's the same threshold we had in DECRA, not the 25 in rescue ICP, and failure of simple measures, so sedation, neuromuscular blockade, get the ventilation right, head up, and various little things like that. 387 patients, 47 centres over a 6-year period, which is actually quite good recruitment for a difficult study. And then the study was ultimately killed by the DSMB. The term that they used in the paper was due to safety concerns, which is a bit of a euphemism. This shows their overall algorithm where they divided treatment into stage 1, stage 2, stage 3. Stage 3 were the barbiturates and decompressive craniectomy. The role for hypothermia, if patients were randomised to hypothermia, was after stage 1 had been done, but before stage 2, and that's where they were randomised to induced hypothermia or not. They certainly achieved what they were trying to achieve. Up in the top right, you can see the temperature differences. So the normothermic group were kept normothermic. The hypothermic group achieved hypothermia, not spectacularly. They were trying to do 32 to 35, and it firstly took 2 days to really get down there on average. But there's a difference in temperatures. I was surprised to see that there wasn't much difference in ICP. So we certainly use hypothermia to bring down a febrile patient, and that affects ICP. It appeared not to make much difference to ICP here, which was kind of interesting. In terms of outcomes, there were certainly fewer patients in the hypothermia group that went on to get either decompressive craniectomy or barbiturates, so they were managed satisfactorily in their stage 2. But looking at favourable outcomes, and this is back to the conventional Glasgow outcome dichotomy of 1 to 4 and 5 to 8, it was only 20 6% favourable in the hypothermia group versus 37% in the conventional normothermic group, with a odds ratio of over 1.5 for a worse outcome with hypothermia. So that pretty much puts the kibosh on this, at least in that context, and that's the reason it was terminated early. There is the mortality difference. That wasn't a primary endpoint. The primary endpoint was functional. But you can see a lot of this was early deaths by about day 30. After day 30, they're pretty much parallel. So the difference in deaths was early, but it's the functional differences in those who didn't die that was the problem. So this is certainly an issue here. I believe Polar is still recruiting. Shay, that's correct. Yeah. So again, this is the Australian New Zealand pre-hospital hypothermia study. You'd certainly feel a bit depressed being on the management group for that, seeing how unsuccessful this has been elsewhere, but that's still ongoing. So carrying on with the hypothermia theme, this is quite an interesting study looking at therapeutic hypothermia for in-hospital cardiac arrest. This was in JAMA a couple of months ago. This is not an RCT, but shows the power of large registry analyses to certainly draw some sort of conclusions and ask some very, very difficult questions. So there's a registry with the totally non-provocative name of Get With The Guidelines Resuscitation in the US that came into being back in 2002. And that's certainly something to bear in mind looking at these results. This is data between 2002 and 2014, where some quite major changes in practice were happening over that time. But within this overall registry, these researchers pulled 26,000 patients for whom there were data for in-hospital cardiac arrest, as distinct from out-of-hospital cardiac arrest. And then of those, 6% were treated with therapeutic hypothermia, and then they matched those with a propensity score to 3,700 non-hypothermic in-hospital cardiac arrest patients to try and tease out the effect of the hypothermia. The primary endpoint was survival to hospital discharge, but they also looked at neurological survival. And this is the clinical performance category 1 or 2. 1 is normal, 2 is mildly disabled but pretty good. So that's the good end of the CPCs. You guys all know this. Back in 2002, we were very excited. 2 studies that showed hypothermia is fabulous for out-of-hospital cardiac arrest, and I emphasise the difference. These studies looked just at patients with shockable rhythms, out-of-hospital cardiac arrest, who had a return of spontaneous circulation but were still unconscious on arrival in the ED. So it's a kind of a focused group of cardiac arrest patients, but had a pretty impressive difference. So that's a 14% absolute mortality reduction in the HUCA trial, and an even better proportion that had a good neurological function. So that's spectacular. And I think everyone here would probably have changed practice based on those data, and we all got involved in induced hypothermia. One of the issues, which probably wasn't appreciated at the time but was subsequently, was the fact that this was hypothermia versus usual practice, and usual practice actually appeared to be a bit of a fever, so 38 degrees, which is just a spontaneous thing with an injured brain, rather than normothermia for the control group. That was the basis behind the TTM trial, which you're all familiar with, which randomised patients to either 33 degrees or 36 degrees, but not just wild type, let the temperature go up. They achieved what they set out to do, and they didn't find a difference. There was no mortality or functional difference at all. So that's the sort of editorial interlude to the results of this study in 2016, which showed that in this in-hospital cardiac arrest cohort, and they also divided into those with shockable rhythms and non-shockable rhythms, who of course had woeful outcomes, but the survival was worse in those that got hypothermia. Not a spectacular difference in numbers, but 27.4% versus 29.2%, with a significant relative risk. So they weren't better, they were worse with the hypothermia. It's a registry, you need to speculate as to why. That was seen a little bit more impressively in those who had shockable rhythms, where again, this is not the group that was in either Steve Bernard's or the Hucker study or TTM. These are people who are already sick, who are in hospital for some reason, who then go on to have a cardiac arrest, and maybe that's the difference. Again, looking at favourable CPC 1 and 2 neurological outcomes, that was worse in the hypothermia group, 3.5% absolute worse, which is quite a significant difference. We need to speculate why. This is a registry, it's not randomised. These were propensity matched. Depends on what you think of propensity scoring, if that's a good thing or a bad thing, and there's certainly been criticism in the past for various different propensity studies. The propensity does, to some extent, deal with a severity bias where either the most severe group get the hypothermia, or conversely, the most severe were written up as hopeless, and a less severe group got the hypothermia. That at least does get dealt with the propensity group. The final thing in the neuro theme, and that might actually be enough to wind up this session, I find really exciting, because so far we've been talking about all these negative studies, and we're very good with our ANZICS negative trials group to produce sort of large negative studies. This is multiple very, very exciting positive studies. Just in the last 2 years, 5 separate RCTs of interventional radiology doing endovascular thrombectomy for patients with large vessel thrombotic stroke, showing really, really nice outcomes. And I think this is very much a game changer. I'm sure you've all in journal clubs talked about the thrombolysis studies where people have managed to do dodgy things like especially the IST3 trial, which was actually a negative trial at the primary endpoint, but somehow got turned into a positive trial and is now being used as the basis for thrombolysis. I think this thrombolysis stuff's all bloody dodgy. This stuff is not dodgy. This is very impressive. So the paper I want to present is an individual patient data meta-analysis of 5 of these positive RCTs. This was in Lancet earlier this year. So they've got great acronyms. So in 2015, Mr. Clean, Escape, Revascat, Swift Prime and Extend IA were all published. And there's been 3 more, so Thrace Therapy, and my favourite one is Pissed, which might describe us last night, I don't know. These were stopped, still to be published, but stopped because of the positive outcomes of the first 5. This Hermes collaboration got together to do the IPDMA of these first 5. So there's 5 high-quality devices using modern devices. There had previously been some less exciting trials with early generation devices with quite stringent criteria for imaging and case definition, rapid access to treatment in experienced interventional neuroradiology centres, and they're all caveats. This does not mean try this at home necessarily. It means that if you're in a high volume, very good neuroradiological centre, this might be the thing to do. It's also worth pointing out that these studies were all commercially funded by the manufacturers of these devices, who stand to make a huge amount of money if this gets into common practice. But it's looking at patients who've got proximal, so large vessel anterior circulation thrombotic strokes, treating relatively quickly and looking at the functional outcomes. And this is not the 1.1, 1.2, 1.3 odds rate ratio, this is 2.5. So they're 2.5 times more likely to have a good functional outcome with this sort of thrombectomy as opposed to not having the thrombectomy. So this is similar to the GOSE graphs I had up earlier, though this is the modified Rankin scale. It's around the other way. So 6 is dead on the right-hand side, 5 is vegetative, 0 is normal, 1 is sort of mildly disabled. And this is pretty impressive. And just standing there without any statistics, I think you'll agree that the intervention group, both overall on top and divided by whether there was thrombolysis as well or not, in the other two groups, do better and do quite spectacularly better. So if you take what most neurological studies take, and that's a dichotomy between the modified Rankin 3 and 4, 6, 5, 4, 3, between 2 and 3, excuse me. That's what most neurological studies do. What I've drawn there, the pink line is the control group, the red line is the intervention group. There's clearly a big gap between those two lines. There's a very significant difference in outcomes. And that's being tough, saying we only want actually good outcomes. Even if you do what was done in some of the stroke thrombolysis trials, which is to move the line one category to the right, there's a pretty impressive difference. But this is now including very disabled people as good outcomes. But whichever way you choose to slice and dice, I don't think there's any doubt about the benefits there. And for me, that's a game changer. And especially looking at the different subgroups, there is no subgroup where there's not a very clear benefit. There's a couple where the numbers were just too small, like age under 18, for example, to not be significant statistically, but it's all very, very impressive with this beautifully positive odds ratio. So I think that's time, and I'll leave the rest of the good stuff I had there, just to wind up the neuro. So to summarise that, we've got some disappointing things. We're still, I think, very unclear as to what the role of decompressive craniectomy is after the recent rescue ICP plus our own DECRA study. I think therapeutic hypothermia is dead, to be honest. What we're looking at is good normothermia, but as a researcher, you wouldn't want to do a hypothermia trial now after all that sort of stuff. And I want to see good endovascular treatment for anyone that I care about having a stroke. I should just add, going back there, it was divided into thrombolysis and non-thrombolysis groups. Frankly, there's no difference. I don't believe the thrombolysis makes a jot of difference compared to something like this that is very clearly effective. I'll leave that there if there's any questions.
Yeah, we've got time for a couple of questions.
That's what you
Any
missed out on.
questions?
There we go. Yes. I'm pretty sure it was in the protocol. I don't know about the SAP. Certainly the protocol was published. And if you go into the supplementary appendix, there's a huge amount of stuff that they published. They've got the protocol, they've got all their data collection sheets, they've got all the communication with the DSMC, and they've published an incredible amount in the supplementary appendix. I think they did make a deliberate decision to make that cut-off between 5 and 6 rather than between 4 and 5. So it was prospective, it was predefined, and that's kosher. Yeah.
Any more questions? Okay, well, thank you to our speakers today. Very thoughtful range of papers. 2 quick announcements before you go to lunch. Dinner seating is pre-allocated, so if you haven't put your name down on a table, do so, because it closes at the end of lunch. And if you no longer want to go to the dinner but have a ticket, let the registration desk know, because there's a waiting list of people who want to go. Thank you very much.